You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 4th, 2023. This week, some listener feedback regarding observational studies, cardiovascular surgeons, dissent from recent guidelines, aspirin for primary prevention, and fish oil is back in the news again. But first, I want to say thank you to Dr. Sheldon Litwin for the kind invitation to speak at the Charleston HFpEF conference at the Medical University of South Carolina. This is a great city, and now I have an evidence-heavy lecture on HFpEF. It was a great conference, and congratulations. Now, let's do some really nice listener feedback. I received two very interesting emails last week. One from a very prominent full professor in academia who concurred with my strong concerns regarding jumping to causal inference from non-random observational studies. But he also warned me not to underemphasize the role of these sorts of studies in creating hypotheses to be tested in RCTs. And he used the example of conduction system pacing and argued that the many observational studies in the field really created a stimulus to fund the upcoming randomized controlled trial. And I really appreciate that point, and I'll certainly keep it in mind. But I would also add, kind of as a counter, that systemic bias in observational studies can be so strong that it might actually destroy the equipoise needed to do an RCT, or it might substantially delay an RCT being done. But that, of course, would be on us as clinicians. We mustn't let observational studies entrench a therapy into therapeutic fashion. A second email from a young academic in Europe urged me to consider why there are so many flawed observational studies in the literature. His take was that the need for young people to use publications as a currency of advancement is a cause. He knows that this type of research is attractive because it allows cardiologists to publish in a short space of time. And I really appreciated some of his words, and I'll just quote them here. He writes that the need to publish promotes a culture of doing relatively quick research using low-hanging fruit. That is, research that is frequently observational and retrospective, and of course it adds very little to our actual understanding of a clinical problem. If we wasted less time on this kind of research and spent more time on collaborating to answer questions properly, we would be doing our patients a great service by investing time in actually answering clinically relevant questions, doing appropriate science. But to do this, we need to stop judging colleagues based on the number of publications that they have. I really appreciate this kind of feedback. And, you know, I have to say that the whole thing with feedback is really teaching me a lot. Every time someone writes me a message, I learn something, and I love learning. So keep it coming. Thank you again for the feedback. All right, first topic today is that the cardiovascular surgery groups have pushed back against the new revascularization guidelines. Two American cardiac surgical groups, the AATS and STS, have written a rebuttal of sorts to the new coronary artery disease CAD revascularization guidelines. The first thing to say, of course, is that there actually were, in fact, new CAD revascularization guidelines from the AHA and ACC groups. This was published in late July, just a couple of weeks ago. Well, two surgeons were on these guidelines, but ended up withdrawing their authorship. They had three major objections to the guidelines, really two that I'll go over in detail. And all of these objections date back to the 2021 guidelines. Surgeons had hoped that their objections then, in 2021, would have been heard and incorporated in these new guidelines. Now, their concerns may have been heard, but it was not incorporated in these new guidelines. So the surgeons wrote a rebuttal, and on Twitter, Sanjay Kaul suggested that the rebuttal be termed a minority dissenting opinion, much like that they do on the Supreme Court. And I really love this idea, and I'll come back to it at the end. The first issue number 1, the 2021 and now 2023 guidelines have downgraded CABG versus medical therapy in patients with three-vessel disease from Class 1 to Class 2A in patients who have an EF greater than 35% and 2B in patients with normal LV. Now, you recall that the reason CABG had this Class 1 recommendation versus medicines was the very old data from the 1980s and 1990s. Remember also that these studies were actually non-significant, but there was a very influential meta-analysis, perhaps the most influential meta-analysis in all of cardiology. This was the famous Youssef meta-analysis in 1994 in Lancet, and I will link to it. Youssef et al. Found that when you combined the old CABG versus medical therapy trials, there was substantial survival benefits with CABG over medical therapy. That's how the whole thing got started. The new AHA and ACC guideline writers have now downgraded the old CABG versus medical therapy recommendations for two reasons. One, they said that old data was outdated, and of course medical therapy is much better now. And the other reason was references from the ischemia trial. Now, you recall that ischemia was a strategy trial. It was early invasive versus a conservative approach in patients who had moderate to severe ischemia. There were no significant differences in either approach at about 3.2 years, and remarkable in that trial was that patients in the invasive arm had revascularization done almost 60% more than medical therapy. So in other words, patients in the conservative arm got the same outcomes but had 60% less cath and PCI and revascularization. Revascularization in the ischemia trial could be with either PCI or CABG, and PCI far predominated by a factor of 74% of the revascularization with PCI and only 26% with CABG. So here's the connection. The guideline writers inferred from the ischemia trial that revascularization versus medical therapy was quite comparable to revascularization in patients with good LV and ischemia on stress testing, and hence they downgraded it. But the surgeons, rightly in my opinion, pushed back. They had basically 5 arguments of why it was not right to infer and downgrade CABG based on ischemia. First, CABG was only 26% of the revascularization group, and that's too small a sample size to make any kind of inference from. Second, ischemia was only 3-year follow-up, and that's too short for CABG to really show its mortality advantage. Third, the choice to have PCI or CABG in the trial was not random. It was up to the docs at the trial site, and this could have led to bias in choosing sicker patients getting CABG. Fourth, ischemia patients were not representative of patients who usually get CABG in the community. For instance, fewer than half of the patients in the ischemia trial had LAD disease, and almost all patients in the community who get CABG have LAD disease. And another wrong-headed issue with applying ischemia to CABG recommendations was the inherent assumption in ischemia that CABG and PCI were on equal footing as revascularization strategies. The surgeons don't think that's true, and here they point to the 10-year follow-up of the Syntaxis trial, which was PCI versus CABG, and this trial showed a strong trend to worse survival from PCI versus CABG. The hazard ratio was 19% higher with PCI, but in a subgroup of patients with three-vessel disease, that was 40% higher with PCI. That's in Syntaxis. And the second reason they don't think CABG and PCI are on equal footing is the FAME-3 trial, which was, remember, CABG versus FFR-guided PCI in patients with three-vessel coronary disease. Here, they saw 50% better freedom from death, MI, repeat vascularization, or stroke was observed among the patients that got CABG. Now, surgeons would also add to the criticism of using ischemia to downgrade CABG versus medical therapy a large meta-analysis of CABG versus medical therapy trials. This meta-analysis, Gaudino et al., was a paper in the Journal of the Thoracic and Cardiovascular Surgery Society in 2022. I'll link to it. Here, Gaudino and colleagues combined patients from Stitches, Massey 2, Berry 2, and Massey 1 and found that allocation to CABG was associated with a greater periprocedural risk of death, but improved long-term survival compared with medical therapy, and the survival advantage for CABG seemed to become significant after the fourth postoperative year and was particularly pronounced in younger and non-white patients. So again, it's kind of the same thing. CABG needs time to show its mortality advantage. Now, the second issue that the surgeons had with these coronary artery disease revascularization guidelines is the contention that PCI has become an equivalent revascularization strategy. And I've already mentioned the trend to better survival and syntaxes for three-vessel disease, but there was also XL, left main disease, PCI versus CABG, which clearly favored CABG for survival. And even in the trial, Noble trial, which was PCI versus CABG and left main disease, there were fewer late MIs and less repeat procedures, though similar survival. Here, I also concur with the surgeons, and I would admit that PCI has made great strides, but I think in patients with left main disease, multivessel disease, CABG has the edge over multivessel PCI. Now, there was also an issue about too much emphasis in the new guidelines for radial artery access, and I'm going to leave that out of the discussion because it's pretty specific to surgery. But let me get back to the big meta point, which I think is important. The surgeons here have sort of blazed a new way forward that I really like. That is, they have published a dissent of sorts. This is a great idea. Now, I've been on expert consensus and guideline writing committees, and ultimately, there is a vote. It's a vote as how to grade something. Now, that vote may be close. It may be 60-40 or 70-30, but that is not reflected in those little silly colored boxes that codify a treatment. What a reader of a guideline sees is agreement there, but there's not always agreement. So what it would be nice for clinicians to know is that a treatment choice has significant disagreement among experts. One way for that to be known is for a group to write a dissenting guidelines, much like that's done on the Supreme Court. These dissents would be evidence-based and include arguments as to why the same evidence could be interpreted multiple ways, which I love. So I know that this might complicate like quality metrics or performance metrics, but in my mind, it would be a very good thing because that's how medicine is. It's complicated. All right, next topic is aspirin for primary prevention. I don't know about you, but 5 years on from the 3 big and null aspirin for primary prevention trials in 2018, I still have wrestling matches about stopping aspirin when it is used for primary prevention in the office. A recent sub-analysis of the ASPREE trial further strengthened the argument for stopping aspirin, especially in the elderly, when it's used for primary prevention. Let's go over ASPREE. Recall that ASPREE was a very large RCT, 19,000 older patients, median age 74, that randomized patients to low-dose aspirin, 100 milligrams, versus placebo. New England Journal of Medicine actually published 3 papers on ASPREE. One looked at mortality, which was, get this, 14% higher in the aspirin group, and that met statistical significance, 1.01 to 1.29, so higher mortality. Another of the ASPREE studies looked at MACE and bleeding, and they found that the difference in MACE was not significantly different, but they found a 30% higher rate of bleeding in the aspirin group. And a third ASPREE paper looked at death, dementia, or physical disability and found no difference with aspirin. So the newest study is in JAMA Network Open. This was a secondary analysis of ASPREE, and it looked specifically at stroke and intracranial bleeding. So stroke and intracranial hemorrhage were pre-specified secondary endpoints of the main trial. Recall that the main trial had 19,000 patients. Overall, the rate of stroke in this trial was low, only 6 per 1,000 person years, and I think of that as 0.6% or less than 1%, so low stroke rates. Let's go over some of the specific outcomes of this sub-analysis. First stroke, 4.7 versus 4.6%, so no difference. Ischemic stroke, 11% lower in the aspirin arm, but it did not reach statistical significance. Noteworthy for the atrial fibrillation doctors out there, small vessel disease was the most common cause of stroke, not cerebral embolic stroke. Hemorrhagic strokes, strokes resulting from intracerebral hemorrhage, were less common than ischemic strokes, and the rate of hemorrhagic strokes recorded was 0.5 versus 0.4, not statistically different. Total intracranial bleeding. The totals of stroke and other categories of any bleeding in the brain were significantly greater among the aspirin group. This was 1.1 versus 0.8%. That's a 38% higher hazard, which did meet statistical significance. And so the net among 1,000 individuals taking 100 milligrams of aspirin over 5 years, there were 2.5 fewer ischemic strokes at the expense of 3.5 cases of intracranial hemorrhage, and that finding did not meet the threshold for statistical significance. So my comments on this is that, in my mind, this sub-analysis strengthens the main finding from ASPREE that aspirin provides no benefit and possibly a slight increase in harm in older patients when given for primary prevention. Yes, there's a slight decrease in ischemic stroke, but it's countered by an increase in bleeding. It also bolsters my view that the main reason to see older patients in cardiology clinic is to reduce their medicine burden. Yes, de-prescribe, especially aspirin. My tired old saying, you've probably heard it before, is that primary prevention therapies are designed to make people live long enough to get old. When you get old, it's often time to stop these drugs. Though in the case of aspirin, there is little to benefit even in younger patients when it's used for primary prevention. All right, next topic is fish oil is back in the news. It just never goes away. 2 weeks ago, July 21, I reported on an observational study that combined 17 prospective studies that had data on the actual levels of the omega-3 fatty acid concentrations and AFib incidence. This paper was in JACC, and it found that circulating EPA level in the blood or adipose tissue was not significantly associated with AFib, but interestingly, higher levels of DHA, EPA and DHA, and DPA were associated with lower AFib risk. So that was interesting and provocative because of the clear signal of increased AFib risk that's been observed in the clinical trials. Now, these higher AFib risks in trials have been well documented in a meta-analysis. The first author of that meta-analysis is Boris Genser. It's in Circulation. I'll link to it. They found a clear dose-dependent signal of increased AFib that was greater in the trials testing more than 1 gram of supplement per day. Now, the discrepant results were explained by the idea that in the observational analysis, that the levels were actually lower, and it was more consistent with eating fish rather than high-dose supplementation. Well, now a Norwegian group has added more heft to this fish oil-AFib relationship. Peter Meyer and colleagues have published a secondary analysis of the OMENI trial, O-M-E-N-I trial. OMENI was a RCT, was published in Circ in November of 2020, and it compared 1.8 grams of omega-3 fatty acid versus placebo, and the placebo was corn oil. The supplement had 930 milligrams of EPA and 660 milligrams of DHA. Now, there were 4,000 patients, mean age 74, and they had all had a recent MI. So these were high-risk older adults. The primary endpoint was a composite of MACE, MI, revascularization, stroke, death, and heart failure hospitalizations. They followed patients for 2 years. And they also measured the levels of the serum fatty acids, and it was a null trial. Many was null. Hazard ratio 1.08, and the confidence intervals 0.8 to 1.4. So no difference in MACE in these high-risk older adults. The OMENI also had as its secondary endpoint AFib incidence, and this almost made significance. 7.2% AFib in the fish oil group, 4.0 in the placebo arm, hazard ratio 1.84, but super wide confidence intervals at 0.98 to 3.45, and a tantalizing p-value of 0.06. Now, the most recent sub-study aimed to assess risk and potential mediators of AFib, and they come up with this new finding called micro-AFib. They defined micro-AFib as short AFib-like activity that is defined as a sudden onset of greater than 3 consecutive supraventricular beats, irregular RR intervals in the absence of P waves, and it lasts less than 30 seconds. I went to the source reference to see a picture of what they're calling micro-AFib, and to me, it looks like what we see on Holter monitors, and I call it atrial junk. Kind of like a just rapid atrial activity, like a non-sustained atrial tachycardia or non-specific atrial tachycardia. To me, it doesn't look like the classic Hasegawa-like focal AFib that's been described. At baseline, about 75% of these 4,000 patients had no history of AFib, and during follow-up, 43 patients had new-onset AFib, 39 detected during standard follow-up, and 4 by doing thumb ECG screening on a device. In addition, 27 patients had episodes of micro-AFib, yielding a total of 43 plus 27, or 70 patients who had new-onset AFib and or micro-AFib. Now, the source reference also has found an association of micro-AFib with the development of AFib. In other words, if you have these short bursts, you're more at risk of having AFib. So the main finding in this study was that 11.9% of the fish oil group had either AFib or micro-AFib versus 6.5% in the placebo arm. That hazard ratio was 1.90, and it clearly met statistical significance. Some other interesting findings is that micro-AFib was higher in the fish oil arm by about the same margin, 6.1 versus 3.3%. They also noted a graded relationship with EPA levels, but not DHA concentrations. And in this really kind of complicated type mediation analysis, they surmised that changes in the EPA levels explained almost 70% of the increased EPA risk. So my final comments are that this sub-analysis certainly strengthens the AFib fish oil risk relationship. It suggests EPA as more of the culprit. I think it also weakly suggests that EPA may play a role in AFib by inducing these micro-AFib episodes or atrial ectopy. That's just a theory. And the way I would parse the trial data versus the observational data that I presented 2 weeks ago is sort of four-pronged. First, there's clearly a strong dose-dependent signal from RCTs that fish oil increases the risk of AFib, and RCTs are simply stronger than observational studies. Secondly, previous work has certainly correlated AFib risk with EPA much more than DHA. Third, the higher rate of atrial ectopy or micro-AFib may be a mediator of the increased AFib risk. And finally, of course, observational nutritional studies are at a high risk for confounding, and that is that healthier people take fish oil, and that healthiness may explain the lack of the AFib signal that they found in the observational study. So finally, while we still don't know the mechanism as to why fish oil supplementation seems to cause AFib, there is a clear enough signal that I tell patients about it. Now, the other advantage of telling patients about this signal is it's an indirect way to give time to heal AFib, right? Recall that AFib often has a varied natural history. It often goes away on its own. So if you ablate AFib early AFib ablation, you may attribute ablation success to the spontaneous remission of AFib. My AFib went away spontaneously. I have a partner whose AFib went away spontaneously. I've seen patients recently this month whose AFib went away with time. So if you tell patients to stop fish oil and give it another month or two, you may decrease the number of people who you expose to the risk of atrial esophageal fistula from ablation. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating. Even those little 1 or 2 sentence reviews help others find us. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.